Hello, I'm Dr. Michael Wright. My favourite piece is The Knight.
Hello Michael, look, thanks for joining me for a game of chess today and also for an interview. Now, we're going to start off with a game of Blitz chess and then do a little bit of an interview afterwards. Is that all right?
Yep, sounds great.
Now, do you know how the chess clock works?
I think I make a move and whack that.
Hit the paddle,
Yep,
that's right.
okay.
So I'm just going to start the clock. There we go.
Okay.
All right.
Okay, I'm off.
You're off.
Okay, I will. There we go.
Now, you mentioned that the Knight is your favourite piece.
Yep.
So why is it your favourite piece?
I like the fact that it can go in multiple directions.
It is a unique piece, you know, the L-shaped moves. It's a very tricky piece. It is my favourite piece, I admit.
Okay.
Now, one of the prerogatives I have as host is I distract people with questions during the game.
No, it's good.
Now, you're the president of the Royal Australian College of General Practitioners, RACGP. How long have you been president for now?
So it's coming up, just crossed over the halfway mark. So it's a 2-year term, and I am into, just crossed over the second term. Sorry, second year, if that makes sense.
Take that for you.
Oh yeah, thank you.
No worries.
And yeah, so I mean, I'm a GP. I've been GP for about 25 years. My dad was a GP, so kind of always grow up thinking there was great value in what we do as GPs, but often people aren't aware of it. And I think that was one of the reasons why I thought I've become more and more involved with the college over the years, and then most recently in this role.
And when you say GP, you mean, so in North America, this would be as a family doctor, family physician,
So like a family physician, a family medicine doctor, as some people call us. Which, so you kind of, the front door of the health system, I suppose, is what we'd like to say, is that people come to a GP with whatever, and then it's really our job to try and, I feel like I'm talking to slow us down, but I shouldn't do that. That's not my intention. Okay, let's. Yes.
Yep.
Oh, okay. Oh God, this is going to be a quick game.
And how have you found being president over the past year?
Look, it's amazing. Like it's such a big organisation, and trying to understand what the needs of all of these patients, and so sorry, I didn't do that again.
That's fine.
Try to understand what all of the needs of this vast organisation. So we've got over 50,000 members. And who are either working as GPs or are working towards career in general practice. And so trying to, I suppose, meet their diverse needs is fascinating, but also, a challenge, because there's a lot of different challenges that GPs have all around the country. So I mean, but the college does lots of things. So we train 90% of the GPs of the future. We set standards for general practice so that people get safe care. And then, a lot of what we do is, working at what's changing in practice to make sure that people can see a GP who they want to or need to. and making sure that they get high quality care, which is kind of at the core of what we do. And it's a and so there's, but as I said, interesting. Look, that's one of the newest things is there is a lot of media work, which, kind of getting the voice out there about the great things that GPs are doing, which often people don't know. And so that's that's an important thing to. Sorry, I got a bit distracted there. No, I was saying, so trying to, deal with changing challenges. There are different priorities. I mean, I've been involved with the college since the COVID pandemic, when I sort of saw the amazing things that GPs did then to keep our patients healthy, and the challenges that there was as GPs as we really tried to keep people well. And then more recently, we're doing a lot of stuff with AI, trying to...
Time's actually up.
No, so what does that mean then? Do we keep going? Or?
No, it means you've lost.
Okay.
But look, thanks for the game. The game is meant to just start off the interview.
Okay.
So you were talking a little bit about, I suppose, some of the things you've been working on over the past year, and you mentioned, one of the things I've discussed, I think, with the previous interviewee is, hot topic is artificial intelligence, AI, in health. And I know that you've I've seen some of your photos, follow you on Facebook, on some of the hackathons, I think, that the college has been involved in. So tell me a little bit about that, where you see the college's role, or potentially where's that going to go?
No, it's a good question. I mean, I think as we're surrounded by increasing technology, and I'm really keen to make sure that GPs understand it, but also use it safely to help our patients so we access care. I mean, there's a lot of discussion about, AI replacing all of our jobs, but increasingly I think that AI will assist us to make better decisions, but we need to understand it to get that assistance, because if we don't know what we're doing, we really are just handing everything over to the AI. But actually, I think AI can be a really great support for making us better decisions.
The way I see it, I don't doubt at some point in the distant future we will have nominally artificial general intelligence. I actually don't think that's coming anytime soon, to be honest. And the enthusiasm, I think, for the large language models is based on, I think, a lot of anthropomorphized how would you call it? It's not delusional, but I think it's a serious misunderstanding of what the models actually are doing. And I actually recently gave an analogy. I gave a talk to UNSW from the perspective of chess. All the frontier models cannot play chess. And it's a simple game insofar as the rules are very simple. A child can learn the rules and play it consistently. And it's concrete. You follow a set of rules, you go by first principles. Ostensibly, you can call that reasoning if you wanted to, and none of the frontier models can do it. No. They'll either cheat, which is hallucinations, or they'll be easily beaten by a 1970s algorithm. So when it can't do that, you can't tell me it's looking into people's records, looking into literature, and actually from first principles doing reasoning. What it's doing is the appearance of reasoning from statistical methods. And that's fine, that's actually really good. It's actually amazing, but it's not actually reasoning. And
as you say, it's that whole, that it's predicting what it thinks the next likely thing will be.
Exactly.
Even if that makes complete nonsense.
That's right. That's right.
And that's interesting to know what it thinks the next most likely thing will be. But does that inform our health decisions? Probably not. Unless that's the question that we're asking is, what is the next most likely thing that this will be?
That's right. And I think, the LLMs, I think, are extremely good at approximating a response. And so when that response, where an approximation where it looks good enough is actually good enough, that's perfectly fine. Like, if I want to format a document in a particular way, it could be done a million different ways. As long as it's readable and it is cogent, that's fine. It doesn't have to be a particular way. While often in certain domains of reasoning, there actually is a correct answer, and it's a very narrow correct answer. And so approximately is what we just call bullshit. It's not the right answer.
It's not just good enough.
Yeah.
And also, particularly if it has to come to an answer and the answer is incorrect, the incorrect answer is more damaging than not having an answer at all. Because I think, as in general practice, one of the things is we work with uncertainty. Lots of people don't have a diagnosis yet, and that diagnosis will come out over months or years. And if an AI, predictive model says, "Oh, I think it's this," it does certainly colour everyone's actions after that. And then it's almost like removing that diagnosis before you can actually get the true diagnosis in some cases.
And the LLMs obviously are extremely good at manipulating language. So I think for summarization, it's actually very, very good. And particularly if it's something you as the human user can immediately verify. So even for something, I know it's a little bit controversial for, let's say, a consultation summarization, note-taking, because you are literally there, you can verify whether it's accurate or not. The problem is on aspects you can't verify. And so if you're looking at somebody else's notes as written by AI, how can you know whether it's correct or not? You weren't there. So the trust becomes an issue. But clearly when used in a certain manner, it can be safe and can be very, very good. From the perspective, again, I'm not going to take the college's stance, but from your perspective, let's say we're just at the beginning of 2026, let's say 2027 into 2030, where do you think, what do you think, general practice in 2030, what might it look like in terms of technology use?
Yeah, I mean, I think already we're seeing the rapid uptake of the consultation scribes, so scribes to support us to write our consultation notes. Now, I think that will continue, but there'll be a ceiling to it where not everyone will want to use it. I mean, it's a bit like when computers first appeared on GP's desks, let's say 30 years ago. There were some early adopters, then the majority of us sort of came along, particularly when there was benefit to our workflow. So things like, being able to write prescription, like not needing to write on a prescription pad, but being able to do electronic prescriptions. And potentially there are some real administrative bugbears in our work, which you probably writing prescription, having to call telephone lines to get approval, filling in forms that don't integrate with our medical software. Now, if AI is going to help us get through around those sort of things, I think that will help the uptake, and I think it's got great capacity to do that. It's just trying to work out what are the the cases that the examples where we do want to that AI will actually be a solution. So I think that'll be helpful. But you see practices already that have things where there's a device where you come into the surgery and you can put your arm in your blood pressure and you can have that done now. I think that kind of technology is getting a lot cheaper. It's impersonal though, so it removes so I'm not saying that's a better thing, but for some people they may want to have that data. I think also people will have more data from home. So, whether it's on our iPhones or our Android devices, that a lot of people are bringing in apps to me and saying, this is what my app. Now, the challenge with that is there's a lot of noise, there's a lot of information there, and how much of it's useful. So, on some of the devices, people have got, if they develop an irregular heartbeat, and that might make you more likely to have strokes and things like that. That can be helpful information. And other people come in and talk about their sleep cycle, which, and some of it's about more on the health lifestyle optimization side rather than the disease seeking side. So I think, potentially, and that's going to be one of the challenges for us, like as a medical professional, as a GP, is working out, obviously I'm trying to help people to live their best life, and more of this is about healthy lifestyle as well as treating their disease. And maybe we will get a shift more towards lifestyle management, but we still have to do the other things. So that's the challenge of, do we have the capacity to do it all?
Yeah, and I suppose, it's a more philosophical question, really more for society, I think, is this what we even mean by the good life? Like, there's this quantification of biometrics, because I think, I suspect you as well, have seen patients, they're bringing their devices and their wearables, and sometimes you think maybe it's useful. Like, is this data real? Maybe it is. Yeah. Is it interpretable? Don't know. And you can do the pretense it's interpretable, and if the patient finds meaning in making behaviour change, doesn't matter. But then clearly there are times when I've seen someone where effectively they've developed an anxiety disorder around minor abnormalities for example, on their heart rate. Yeah. And so they keep measuring it 100 times a day, and actually the measure is driving the anxiety. The anxiety is what's causing the tachycardia, and they actually just need to detox. They need to stop using the device, and they'll be fine. And I wonder how much, you mentioned as noise. One could believe, I think it's plausible that some of these measures are potentially predictive of something. Yeah. We don't know what they are, because no one's ever done any research on that. Let's say even if you find minor arrhythmias on a device that measures a pulse rate, but basically 24/7, 365 days. Do they mean anything if they're all asymptomatic? We don't know what rate of those are actually just within normality.
Yeah. What's significant, and and I suppose even what's the usefulness of measuring all of this data, when maybe if we turn it off, people might have a happier life, particularly for the people who do get anxious.
Yeah.
But maybe that's what we do as as GPs. I feel like that is our role, is to work with people to understand the data that they have, and hopefully reassure appropriately when something does sit within normal range. But that's one of the things I think we do as GPs, is by seeing people multiple times over a longer period, we tend to get a sense with our patients of what's normal for them. And maybe, and I do think that, I think we perhaps jump, I know I do, you jump less quickly when you know someone and you've seen them, you feel like, well, I think this, this might be my perception of what these symptoms means. Let's go down that path, but also knowing that if I'm wrong, we'll be able to follow this up in the near future. So there's you're not sort of letting someone slip through the cracks, which I think, because we see people on multiple times and we expect to see them again, we can work out the success or otherwise of what a particular treatment, or not treatment, if we observe people and say, look, I think we can just watch this for a week or two. I think, and that's something that I don't think technology particularly allows us to do. I don't know that you see that many technological solutions where it says, don't worry about this, we're not sure what it is, but it'll probably go away.
Well, that's right.
Uncertainty doesn't come much through with technology.
Well, that's the thing that doesn't, of course, come with ChatGPT, where you ask it a question and it goes, well, look, I actually just don't really know. And perhaps part of the, when they talk about guardrails and things like that, part of the challenge is that ChatGPT and most of the LLM chatbots will be extremely unuseful. Well, we're practically useless if they actually presented their answers in the genuine language of uncertainty that exists. They'll say, look, I'm not really sure, but maybe it's this. Why did I been asked this? As opposed to just Google the answer directly.
Because I think even, and I don't know but you think with the LLMs, they do predict the most likely response. So I'm just going to cough. I'm sorry. If that response is 51%, okay, but maybe it's 30%, and there are 10 other, it's still only less than 1 in 3 would pick that response. There's a lot of other alternatives.
Yeah, and it's not predicting the most expected response from the perspective of its training data. And of course, if the further away the phenomenon is in fact from something that could exist in training data, the more likely it's actually just saying a bias.
Yeah.
It's not saying what's real, it's saying a bias because that is what you would expect to see in the training data, but it's not real.
Yeah.
Yeah. Now, Michael, you're someone who has a PhD. I think, I remember when you first became president, I think at the college conference, not last year, 2024, and you and Mark Butler, the health minister, were on stage, and he sort of noted you both kind of look a little bit similar. But he sort of noted that you're also a health economist, and you've got a PhD in health economics from
University
UTS,
of Technology
in
Sydney,
Sydney, which is actually just a couple of 100 metres away.
I did a lot of my PhD study just up the road. Yeah.
So can you tell me a little bit about your doctoral studies? What did you study and what did you find?
I was very interested in continuity of care. So this idea that if you go and see if you have care from the same GP or the same practice over time, do you get better health outcomes? And there's some international evidence to suggest that, but I hadn't found any Australian evidence. So I thought this is something that I want to quantify it. So as a GP, I like seeing people who I've seen before. I think I do a better job, but I didn't know, is it better for them?
That's right. The lived intuition is surely it must.
It's probably a good thing, And you feel like people don't have to go and explain the whole history every time, and probably that's better for them. But then I thought, well, maybe it's not better. Maybe maybe having multiple people involved, you get different sets of eyes, so it's better. But I sort of thought I wanted to quantify it. So I did my PhD at the business school at UTS in health economics, looking at if you could quantify what is the impact of having continuity of care. So did a number of studies, but the main one was looking at cancer screening. So looking in using a large data set, looking at women, so it's called the Australian Longitudinal Study of Women's Health, where we're asking women for 20 years, had you had your regular breast screening and had you had your regular cervical cancer screening, so regular Pap tests, and trying to work out was there any pattern between whether women said that they had the same GP or went to the same practice but saw different GPs, and whether they had that cancer screening compared to people who went to multiple practices. And essentially what we found is that women who had all their care, compared with women who saw multiple practices, women who went to one practice were more likely to have appropriate cancer screening. And also women who had all their care from one GP were also more likely to have appropriate cancer screening than women who saw multiple GPs within a practice. But the main difference was between the multiple practice and the single practice attendance. So potentially that continuity from information, from having all the shared record, that has a benefit. But there was also an additional benefit, although smaller but still significant, that if you had all your care from one GP, potentially that relationship where you got all your care, potentially we both sort of have this shared responsibility to one another that I would say, look, I think it's time for your test, and that potentially you might say, oh, okay, yep, I'm due. Trying to understand the value of that. And so that was what the PhD was about.
Sure. And was the result, did that seem to be maintained when accounting for, let's say, people from different socioeconomic groups?
So we accounted for a lot of, there were a lot of variables that we controlled for, sort of including income status, education. We did look at age, we looked at state of location, medication use. I'm trying to think, there were about 15 of them that just tried to control all the other variables. So potentially people who are wealthier can afford to go and see the same GP all the time, whereas people who have less resources might have to shop around for whatever. But even when we controlled all of that, the significant differences were maintained.
So that result seemed to be robust across that. And this is something. I'm really pleased that there's that result, because I suppose it sort of meets my expectation of what we should find. But did you? I suppose. Now, a concern in particular is I've sort of historically worked in southwestern Sydney, which is a relatively low income area. So in fact, one of the lowest income areas across Australia. And one of the things that we have observed before, because one of the things people say, people from South Wales, they don't get to go to see a GP, so they go to emergency departments. Yeah. That's actually false. When you sort of actually look at the data, I think the median number of general practice visits is in fact higher in southwestern Sydney than other parts of the country. Not grossly high, but it is a little bit higher. Yeah. But one of the things is that there's also a higher number of individual GPs seen across a unit period of time as well. So there's less of that continuity. And one of my concerns is some of the health reforms to try to improve access have largely focused on access insofar as seeing anybody, as opposed to supporting continuity. And in fact, some of the changes may in fact be impairing or could damage continuity, hypothetically. Yeah. What are your thoughts about that?
Yeah, I mean, I think the evidence is that trying to encouraging people to get care from their same GP, from the same practice, would actually be beneficial. So I think if we set up the incentives to encourage practices to seek care from their preferred GP, that would be ideal. And I know what you're saying. Like, if we all open up alternative pathways where you can go and see a GP, or you can go to an urgent care centre, or you can go and see a pharmacist, or you can go in Queensland, they've got satellite hospital. You can, all these people, it really does fragment care, and it adds extra people, and particularly if people aren't sharing a single health record, there's very little accountability, and the international evidence shows that you get worse health outcomes.
Yes.
No, so I think it's an important point you make, that actually trying to support people and providing incentives that encourage people to go to the same practice definitely would encourage that continuity of care and reduce that fragmentation.
Yeah.
And we do, and some of the measures have been designed to do that. Like my Medicare, the idea has been that that encourages people to go to the regular GP, but without incentives for patients and the GPs to provide that care, then it's a little bit hard to see how successful it will be.
So you were mentioning sort of a couple of dimensions.
Different types of continuity.
Yeah, different types of continuity. So informational continuity and also relational continuity, and sort of in my sort of naive sense, both seem to be enhanced or maybe even be required for sort of local teams for it to really work well. So, for instance, if I'm working in a clinic, it's okay. If I'm working in a local clinic, if my medical records aren't quite up to snuff, that has an impact on my colleagues, it has an impact on my patients. It's likely I will get feedback from other people within the health system. Yeah. While I would imagine, even though it could potentially work, that for people outside, if everything was external, you're much less likely to have that work quite as well. So what are your thoughts about the mechanisms of how we make that work?
I suppose, and I know you mentioned sort of relational and informational continuity. The other one we often talk about is management continuity, which is sort of that where there's some consistency in how we care for things. So it might be like, if you come and see me with pneumonia, I'm likely to give you certain treatment, and if you go down the road and see someone else, I'm going to provide you. So there's some continuity there. Yes. So there are some benefits from that predictability of us doing similar things. But I think you're very right in that the informational continuity can help. So if someone's travelling interstate and they've got access to the same record that I've got, then that will help them even if they don't know the person. But they're still trying to operate within a certain team. And as I said, for general practice, the core of what we do is providing care over time repeatedly. So just everyone doing something and adding it to the record isn't really helpful, because if particularly people haven't looked at what's in the record and no one's actually learning from what's being put in the record.
That's right.
So I think I was going to say that's a challenge. And I think locally, with the whole idea of increasingly we're talking about in general practice working more in multidisciplinary teams. So you've got a GP, but you might have a nurse, you might have a pharmacist working in the practice, or a psychologist. All of those people need to work together, and having a shared record is fundamental to that. But also knowing each other and sort of understanding what each other's roles is critical to that too.
Yeah, so as you know, I worked sort of largely within mental health, and this is sort of multidisciplinary care is, I suppose, part of the model of care for people living with severe mental illness in that specialised mental health scene. And like certainly things like team meetings are not replaceable just by medical records.
Yeah.
And so actually having humans talking to other humans, where it's important and salient, and I can certainly agree that in community practice it may not be quite as important all the time, but the record doesn't replace that. And just like my personal knowledge and memory of seeing and speaking to one of my patients over time cannot possibly be replicated in the record, because even if you wrote down an entire transcript, there'll be hundreds of pages. As another human reading it, you're not going to be able to absorb that lived experience, and wouldn't be reasonable to do so anyway. So there is, I think, something about the fact that our interactions are fundamentally with humans. Our patients are humans. And so to me, the continuity, that relational element, that local, actual face-to-face interactional element sort of demands, I think, a certain respect for locally based teams.
And I think as GPs, that's what I feel like for a long time we've got. I think this is what we do that's valuable.
Yes.
That having that relationship, understanding our patients and treating them more than a series of entries in a record is the sort of difference that we have. And that's when people say that, my GP understands them and they say that's the most valuable thing that they've got. I think that's where that comes from. Yeah.
So the patient is not an object in a medical record system. That's a certain description that enables care, but that's not them.
And that record can facilitate to keep some information that might be useful in the future, but it doesn't replace the person in front of you.
Now I'm going to change tack a little bit. So because you're sort of at a senior leadership level within the College of General Practitioners, and also from your health services, health economics sort of perspective, imagine you have a magic wand and you can reconstruct the health system as you choose. So you're God. So not constrained by what's happened in history and exigencies of what can be voted in and what won't be voted in. If you could magically change it to a way that you think would be optimal, what would the Australian health system look like?
Okay, it's a fun one to think about. I mean, I do think fundamentally we don't place enough focus in Australia on prevention and health promotion and keeping people well in the community. So if I was to redesign it, I would shift resources and focus towards more prevention, promotion, primary care. So basically designing keeping people well in the community rather than waiting for them to get sick, get to hospital. Now, one of the challenges we do have in Australia is we have a federated health system where the states control the hospitals, the federal government controls community care, for want of a better word, although the federal government does pay for almost half of the hospital budget as well. And so that challenge means that there's a great resistance there. So changing that, I mean, we've talked a couple of times about in our history of ending the blame game. So if one side of politics, or if one sort of arm of government, they were to agree that there was a single oversight, potentially that would create some greater efficiencies, but it potentially then just creates a single system, which some of in Australia, some of the tension between states and the federal government, does create some innovation, and also the balance of having a public system as well as with an element of private creates. So although they created more complexity, that tension between those different models may actually be in our long-term benefit. When you look at other countries who have, the UK has a single publicly funded system, which is under great pressure, but due to underfunding over decades. Whereas in the US, there's a large private component at a high insurance level. So, and if you are insured, you get really good care, but there's a large proportion of the population who don't have access to care. So in Australia, we do currently have I'm not going to call it a happy medium, but in between those is probably the way we want to be.
interesting thing. It's kind of like a prisoner's dilemma, right? Like, because you can certainly design a centralised, as a government-run health system that, if it was well funded and it was pretty efficient, you can sort of you can sort of design the quality and the service level that's agreed by the population. Based if you live in democracy, and similarly in a purely privatised system, if you want more, you pay more. If you want less, you have less. From the perspective of, let's say, car insurance, that's all privatised. With a certain degree of regulatory oversight. But what we have seen worldwide is, with those models, they tend to have corrosive elements, which are they become very efficient at not being very good, and they get a bit stuck. And what you're saying is our mix of private and public maybe stops some of that settlement into...
And exactly, and that as you said, if you had a well-funded system, but if it's completely publicly funded, then who decides what's a well-funded system? And if you have times of austerity, you just tighten the belt, and that's what people have to do. And we've seen the consequences of that in the UK, with sort of increasing pressure on the NHS and and worse health outcomes. So kind of and I think that's why there's a lot of reticence in Australia to go down that path, because being completely reliant on the continued goodwill of whatever government, whatever economic circumstances, has proven hard.
From a macro perspective, again, from the perspective you can wave magic wand, how much, what proportion of health funding, again, if you're the health system god, should go to, let's say, primary care, as opposed to secondary, tertiary care, public health, and population health? Where do you think that is, in terms of ballpark sort of funding?
I mean, some of the research which I've been doing has been looking at the percentage of the health budget that goes into primary care. And I suppose by primary care, I mean high quality, first contact, comprehensive long-term care, like you get from a GP in Australia. Other places you might go to a family medicine doctor. And the percentage of the health budget that's been going to providing that care has been dropping year on year for most of the last decade. So we're close to sort of 8% back in about 2013, 14. And I think in the most recent figures, it's less than 6%. So essentially the funding that's been going into general practices has been pretty static. So it's around $400 per person per year. But the figures that basically the increase in hospital expenditure has been going up. So the amount spent on hospital per patient on public hospitals has gone from around $2,500 to over $3,000. So there's a relatively small increase in investment in general practice, I think, would have a big impact. So if we got back to 10%, like that would be a reasonable starting point. I mean, if we get to 20%, that would be miraculous. But also, if you ask patients, there's a survey that a colleague ran, just asking patients how much of the health budget do you think goes to general practice? And the average person thought about 30% should be going into GP services. It's actually, as I say, probably less than 6%. So maybe asking patients what they want is, is something that also could we do to inform the mix.
I do find it interesting when people say that Medicare is unaffordable, where these are, in my view anyway, now I'm not in government, so obviously it's more difficult and more complicated than what I'm saying. But to me, these are choices, because the total quantum that goes to general practice, Medicare is more than general practice, but the total quantum that goes to general practice is actually pretty small.
If you've got the pie, I mean, it's a very small piece of the pie. It does go to support general practice, and we provide over 170 million visits a year. So nearly 90% of the population goes to see a GP. So there's high levels of contact, high levels of access. The stats which I saw last year, which I thought was really interesting, when 99% of people, when you asked them, could you see a GP when they needed to, said yes. Now, some people had to pay for it, some people had to wait longer, but 99% could see a GP. And that's pretty spectacular access. And I do think it's something we should be proud of. So even when you say, the whole idea of waving the magic wand and starting again, we're probably starting at a better place than most people. And so I'm not, I probably don't think we need to throw everything out and start again. I think as I said, there are some real features of our system that are positive, that do act as checks and balances.
Yeah. I think fundamentally part of it is just quantum of funding.
Yeah.
Like, look, I don't strongly, I suppose, believe in one model over another model, but I think I do have, I suppose, a personal problem when, I suppose, I get concerned when health reform is shuffling deck chairs, like moving money from one pie, from one model to another model, but the total quantum hasn't changed. And as far as I can tell, community medicine is actually quite efficient overall. Now, there's bits of leakage here and there, of course, but it's actually pretty good. Yeah. And Australian hospitals, they're overall probably fairly efficient in terms of what they do as well. So the issue is perhaps configuration and where the money goes where. In Australia, we, as you know, we don't put a lot of funding into population health and preventive health, especially compared to, let's say, the pharmaceutical budget. It's not difficult for new pharmaceuticals to be effectively funded for a good fraction of $1 billion, and that's an annual sort of rolling over budget, while something, let's say, trying to improve access to dietetic services or improving exercise services available for the community, group exercise. That's basically impossible.
Well, I think you're right. I mean, even things, you've seen the new drugs, new weight loss drugs that are very expensive, effective, but they will get on the PBS and they will be subsidised, but you've got a lot of other measures, like group weight loss, group exercise, other things that will actually impact health and weight long term as well. Yeah. But they're not as, perhaps they're not as easily quantifiable, and so because of that, they just become less. They're less attractive to funders because they're less, perhaps less certain.
Yeah, and it's a funny thing, this is issue about certainty, because like some of it is a matter of, it's almost a matter of belief. Like, it's like asking what's the evidence for, primary school education. There's no good evidence for it, from the perspective of clinical trials. But you just have to believe that is the case. There's a very strong theory on why it should.
Although there is a strong economic school that talks about the return on education. So and I think that's a good point, and that's one of the reasons why I've actually have found studying economics quite interesting, because it does talk about the return on. On different types of investment, but those investment can be education, as well as financial tools. And maybe that's something that we don't, perhaps we do look at clinical trials and these sort of hard health outcomes when there could be additional education, group consultations, a number of other interventions we could do beyond medications, but which perhaps they're just not viewed as highly. And which they should be.
Yeah. Look, thank you very much. It was a stimulating discussion. A good game. I think we didn't use the clock quite properly. I hadn't used it for a while.
Sorry, first time for me to use the clock. So sorry.
No, that's all right. I don't normally use the clock.
Instead of waiting for a bell that goes off every 10 seconds, so you're taking too long. Yeah.
No worries. This is a copy of my book for you.
Thanks, Mark. Thank you so much. Yep. I feel like I've got a lot to learn, so thank you.
Look, you played the game reasonably well. I can tell you're a beginner, and I know that you've.
As I said, I haven't played a game of chess since school. I think so. It's quite refreshing to start again. Probably more of a checker's guy to start with. But.
Not at all. Look, if you do decide to play, my interest in chess is particularly with what we call the romantic style, which is less rigorous but more, based on tactics and sacrifices and just basically chaotic chess for fun. All right, look, thanks very much again, and I'll catch you around.
Okay, thanks a lot.
Cheers.
Thanks.